What a great pleasure it is to be here. Can I thank MQ and these magnificent surroundings? Andrew McIntosh told me it's his new London office. So very impressed, Andrew. So I've got this very sort of wordy title, but what I'm going to try and do is convince you of three things. Firstly, I think we've got a fantastic mental health research community in the UK. And I think we're at an inflection point where we can gear up mental health research at scale for the benefit of patients. Secondly, we need to think strategically around data science and something that I call data as infrastructure to benefit all. And lastly, and I thought, Mina, your talk was fantastic. We've got to demonstrate trustworthiness. You're at the back. If we're going to do this, we have to demonstrate trustworthiness and engage and work with the publics as we go. So that's the script. So ignore the title. So I'm not going to talk for 30 minutes, but why is now the inflection point? So where's that? Does anybody know? I'll ask Mina. Do you know where that is? Have you been there? Not been there. It's not Scotland, I could say. So that's Davos, you know. And you know that the World Economic Forum goes to Davos every year, and they talk about a fourth industrial revolution, because we're seeing a fusion of biology, computational science, and physical science. And it's really disruptive. It's changing the world. Why? Because the pace of change is exponential rather than linear. Secondly, it's affecting every country and virtually every market. You know, if 10 years ago I stood here and said, the largest taxi company in the world owns no taxis, you'd think I was mad. But it does, and it's called Uber. And lastly, it's disruptive and it can be corrosive because, you know, as we've seen, it can undermine democracy, elections. So our challenge in health and biomedical research, and that's why research such as Mina's is so important, is how do we harness the fourth industrial revolution in a trustworthy way and for benefit and benefit sharing that's fair. So that's why we're at an inflection point. The other thing is that we're seeing this fusion of disciplines. So, you know, in medicine, I was a diabetes doctor, and we think of cardiology, diabetes, psychiatry, etc. But in computational science, it's the same. What we've seen in the last 5 to 10 years is not only remarkable progress in each of the specialties, whether it's sensors, robotics, natural language processing, speech recognition, but a confluence of these technologies to create really remarkable products. And we're seeing that in our daily life. You know, how could we take a satellite and blow it into something out? Did you see that on the news? In space, to sort of disrupt the trajectory of a large meteorite? That is because of a confluence of technologies. And what we're beginning to see is these technologies coming to healthcare and medicine. So where are we? So this is an Aradazi slide from WISH. What it shows is fourth industrial revolution. What sectors have embraced the new technologies the most? And as you would expect, it's financial services, high tech, telecoms are in the far right quadrant. So health at the moment is mid-table. So we're a bit like a Manchester United because they're not very good at the moment. But what we're seeing is huge investment in R&D, in data science, and that's the fusion of math, statistics, computational science, and domain into healthcare. And this is coming to mental health research very quickly. So that's the sort of technological opportunity. The other thing is scale, and I'd really welcome your thoughts on this. So this is Rory Collins, who runs UK Biobank. And what we've plotted here is the relationship between blood pressure and mortality in the Framingham study, which had 5,000 participants. And if you look at that, there's a relationship. It's a bit murky. So that's 5,000 people, that's 50,000. That's UK Biobank. So scale is becoming increasingly important. Let's jump to cancer. So this is we talked briefly there about clinical trials. So here's a thought experiment in cancer. So if we wanted to work with the publics to recruit 250 patients sick with a specific cancer and biomarker of various frequencies, how many folk would we need in the denominator population to accrue 250 people in a year? And what we're seeing is, because previously we used to cluster disease, in my day, because I'm an old guy, there were 4 types of breast cancer defined by H&E staining that we look down the microscope. There are now 137 defined by molecular characterization. And what that means is that common diseases are actually a cluster of rare diseases. And I'm sure it's the same in psychiatry as well. And if you've got a 1% biomarker frequency for lung cancer, for example, you need 47 million people to recruit 250 people a year. So you could probably do it in England. But when you look out at the rare cancers, you know, if you look at precision liver, it's almost 500 million people at a 1% biomarker frequency. So we're going to have to collaborate at scale if we're really going to drive benefit to patients in a precision-based way. So what we're seeing in terms of the way we're running research supported by data is what I call a sector maturity. Classically, a researcher would know someone down the corridor and say, oh, you've worked to create this fantastic data set. Can I use it? And you had a sort of bilateral relationship. The thesis is that we need to really enhance research efficiency, impact, and productivity by creating a many-to-many relationship. So those folk with the best ideas doing the research, which has got public benefit at its heart, have access to data in a trustworthy way. And that's what we call a mature sector. But to do that, you need data as infrastructure, because you need, not only you need the data, you need the governance, the policies, the standards, the technologies, and the ability to define benefit sharing to make this work. So it's a data as infrastructure. It's a bit like power stations on a grid. You know, we all like our new Dyson Hoover, but we often forget that if you didn't have power stations and electricity grid, it would be useless. So how do we collectively in the research community create the power stations and the grid of a trustworthy data ecosystem? And demonstrating trustworthiness, this is a small survey, it's not as good as Mina's project, but we've got to take the publics with us every step of the way. And actually they make, working with the publics, my experiences, makes the research better. So it's a good thing to do. So that was really the backdrop to this thing called HDR UK, which is the National Institute for Data Science. And we were very fortunate. I thought the funders initially, you know, MRC, Wellcome, BHF, UKRI, we've suddenly got support from Gates and others, was prescient, because rather than having this very fragmented, unstandardized landscape, can we start to create power stations on the grid to make research easier? You know, I've had PhD students who've had to wait 2.5 years to access data, which is pretty tricky when a PhD is 3 years. And I'm sure we've all experienced that. And it's unacceptable. And actually the publics, the patients who are very generous with their data wouldn't want that to happen. So how do we really try to spell that up? So our mission is to unite the UK's health data to enable discoveries that improve people's lives at scale in anticipation of the 4th industrial revolution. So just very briefly, the Wellcome, we are tenants at the Wellcome, and they're very generous with their tenancy. So we are lean in London, but we have tentacles that spread all over the UK. We have a strong independent board, and we've just added to our board. So Ara Darzi, Claire Bithell, Mark Walport, Alison, who was HR director at BT, and Andrew Elder are joining our board. The thesis is, if we tried to do this from University of Cambridge, Oxford, Edinburgh, Glasgow, Birmingham, classical academic rivalry would come to the table. So what we are institutionally agnostic, and we want to support all universities, all NHS partners equally by building this data as infrastructure. And that briefly shows where we are across the UK. We have 8 regions across the UK. And just to emphasize, this is really important for the NHS. You know, we all, I think, are worried about the NHS this winter. It could really, especially with flu. I don't know if you saw last night, the latest flu variant, which was actually quite bad in Australia. You know, there's a real risk to the NHS. Productivity or efficiency of the NHS is probably running at 60%. And we know from healthcare systems internationally, if you have whole system intelligence in near real time, it's better for patients and it's more efficient. So how do we do this? We do 3 things. We unite health data through data infrastructures. Secondly, we have driver programs. So rather than build it and they will come, we say, let's have a research question at scale across the UK and use that to clean the pipes and leave benefit for everyone. And lastly, we're about team science, because it's about collaboration, arguably at scale we've never seen before. So one thing we've done is we've got a UK Health Data Research Alliance. So these organizations have all subscribed up to the principles of trustworthy data sharing, the principles of the 5 safes, of safe data, safe places, safe projects, safe people, safe outputs. And that's a growing international standard for how we share data, and also to make data discoverable for research. So let's just go. And we have 9 data research hubs whose role in a trustworthy way is to curate data and make it discoverable and available for research. And it's fantastic to see Rob and Anne here today doing a fantastic job on Data Mind, which I think has the potential to work in partnership to scale. And lastly, transparency is very important. So again, we're in the foothills of where we need to be, but we have a gateway that anyone in the world can access to see where data are. And now we're starting to provide tools to actually enable requests for access to those data. So it's driven by sort of high-level metadata specification. So I thought I'd just give you a case study, because that's all pretty dry, of how this works. And I thought I'd choose COVID as a case study. So in the early days of COVID, Patrick Vallance said, we need to do some things at scale across the UK in terms of surveillance, longitudinal health, trials, transmissions, immunity. But he also said, let's get data and connectivity sorted for COVID, so we can run studies on 66 million people. So he asked us, Ian Diamond and I sort of led this. We did 3 things. We mapped the data sets, we created this interoperable data infrastructure, and then we made it available to researchers in a non-exclusive way. So if I'm in the University of Manchester, I don't have exclusive use, because if we're going to do team science, it has to be fair. So in the early days, don't read any of this, but in June 2020, those were the data sets available across England, Scotland, Wales, and Northern Ireland in so-called trusted research environments, which are these secure enclaves. And those were the data about a year later. So we've enabled about 115 COVID-specific data sets, but enabled linkage to other data sets. And then we published at SAGE in a very transparent way with all our partners across the UK to say, this is the state of the art of science of COVID in the UK every week during the pandemic. So it's like real-time research monitoring. As part of that, we've created consortia. So Kathy Sudlow and colleagues have worked with NHS Digital to create a UK-wide data asset for cardiovascular disease. We enabled clinical trials, the recovery trial you're all familiar with. So dexamethasone recruitment, about 70,000 people recruited. The DigiTrials hub that we supported enabled automated ascertainment of outcomes in trials. So rather than having a squadron of people saying what's happened to patients, can we use data to actually have a defined trial outcome. And that was led by Marion Maffin and colleagues at Digitrials. And through this system, it affected global policy in relation to COVID in terms of real-world vaccine effectiveness, variants, vaccine waning, vulnerable groups, vaccines escape, vaccine safety. And here's an example on pregnancy. I don't know if anyone can speak Spanish, but they tell me the headline's good. So, and here's one from this week. And it's just to show we can now run studies on 48 million people for cardiovascular disease. But the data infrastructure is agnostic. Why can't we work in partnership and unleash this for mental health research? But this was in Circulation this week. We talk about long COVID. We've all heard of long COVID. Of course, the immediate question is, how long? So what Jonathan Stern and colleagues, very team science-based, I think 6 universities, use this data infrastructure to show that a year out, there was still a risk of major arterial and thrombotic events. And I said to Jonathan, that's really impressive being in Circulation, but it was even better being in the sun. So there we go. So the aftershock, urgent warning to anyone who's had COVID in the last year. So, but this is applicable to other disease verticals. And part of this, and I think the industry discussion is important, because if you look at COVID, the universities and the NHS didn't invent the vaccines. They didn't create the mass manufacturing to enable 4 billion people to be vaccinated. So I think the discussion with industry is not really one of profit and non-profit, it's more one of benefit sharing, which is fair to the publics, the NHS, and whoever contributes to the development. And as part of our next quinquennium, we're going to have 6 driver programs. And a question I would like to discuss with you is, could we have a driver program on mental health research at scale across the UK? So at the moment, we've got medicines, we've got pandemics and outbreaks, we've got the cancer, cardiovascular disease. Could we collectively devise a driver program for mental health research? It does 2 things. It works at scale across the UK to answer an important research question, but it creates this data infrastructure that everybody benefits from. And one example of that, we've got a driver program on medicines. Reacher Soffit and NHS Digital have now curated the national prescribing data set for England. So this is patient-specific prescribing for England, about 40 billion data items, the entire BNF. And Reacher's got an interest in the Cumberledge review, so she was able to link that agnostic data asset and answer really important questions in relation to co-prescription of valproate with pregnancy. So, but these data assets should be used for public benefit for all disciplines. I'm nearly finished. So what are the opportunities for mental health research? I think you've got a fantastic community. As I mentioned, DataMind you're going to hear about today, but it's part of the puzzle. And I know the team are very collaborative and would really wish to work in partnership to build it out. Some other things, these are non-exhaustive lists, but my mate Richard's done great work on natural language processing to try and derive phenotype out of raw text. We've got increasing devices, wearables, which will also enable the phenotype. So this isn't just an NHS project, it's about multimodal, multidimensional data, and how do we curate that? And what we have to do is invest in the next generation. So how do we advance research? And I heard a wee bit of the panel discussion, but the next generation of mental health data scientists, we need to support, and be really keen to discuss that with you. And as I said, with MQ in the center there, we've got fantastic community upon which to build. But lastly, we got to do it in partnership with the patients. Throughout COVID, they commented on every one of our 38 reports to SAGE. The publics actually helped us present the data to the scientists and the policymakers, and prioritize the research questions. Public engagement makes our research better. So to finalize, I'd like to suggest, team, the time's to be bold, ambitious, and enterprising. I think we're in a good position in the UK with the leadership we have, but it's, can we scale this? And in other sectors, they have this expression, collaborate at the interface, compete at the implementation. But what we tend to have in universities and academia is everyone just wants to compete all the time. But actually, it's for patient benefit to try and agree on these, these common data assets, data infrastructures, governance policies, which actually benefit everyone. That's the opportunity. And in that way, I'll go back to my title, then we will be able to develop a UK-wide trustworthy data infrastructure for research and innovation in mental health, because that's what patients need. And just to show I'm not the only one who's thought of this, so this is now the president, is it the president of Italy? It's Prime Minister, yeah. So I shouldn't really be showing that. I didn't read that article in this week's Economist, but I did read the article on fixing the brain, suggesting that we are at this inflection point where new developments such as neuroinflammation, optogenetics, but also data science is leading to a renaissance in neuroscience and mental health research. And you are at the forefront of it. So I'll finish there. Thank you very much.
Thank you so much, Andrew. That was absolutely fascinating. I learned a lot, and I think probably everybody in the audience did. I can see we have a question already over there from our own Louise Arsenault.
Thank you very much for a very interesting presentation. It's just a point of clarification. I think that you mentioned something about Data Alliance a few slides ago. Can you just remind me what their purpose is? Is to make data available?
So a challenge in this space is the lack of standardization. And when we were developing this, we looked at other such successful data ecosystems. So for example, I could send you £100 in the next 2 minutes. And that's because your bank and my bank both subscribe to something called the SWIFT system of messaging and IBAN codes. And that enables trustworthy data access and trustworthy transfer of money. I won't, by the way. So what we thought in the UK, everyone was doing their own thing, their own policies, their own approach to data access, their own approach to transparent data use registers. So what we did is brought this alliance together, and they all subscribe to FAIR data principles, which is data that are findable, accessible, interoperable, and reusable. And then what we are doing is doing the heavy lifting of trying to introduce these common policies, common standards, which makes the whole thing work more seamless. So it's signing up to those principles.
And can I just check? I could see the logos. Some of them you have to pay to have access to those data. So does that apply to FAIR principles?
Well, the whole issue of this ecosystem, again, I don't think it's, there are nuances in terms of the cost of running. To keep a data asset relevant, alive, and up to date has an idling cost. And I think we've got to be honest about that. This doesn't often come free. So, but one needs to be transparent and say, well, these are the costs. And these are the cost recovery mechanisms which actually enable us to nurture this resource going forward. So there is a mixed economy, but again, this is about transparency of how business is done.
It would be interesting to kind of find out who should pay for those costs. Is it the data users? Is it the funders? Is it the studies? But I think that if you have to pay for data, it comes in between being accessible, I think.
I do. But it depends what that's in my view is that there probably will be a cost. But if we get this right, you drive the cost point down as low as possible, because that's what the patients would want. So, but there are, we're doing a lot of work shining a light on the different business models across the UK, and it's a cottage industry. Everyone's doing their own thing. But over time, we hope to get to not only fair data principles, but very transparent and fair pricing models. Because at the end of the day, it's cost benefit as well. So I'm becoming an economist. So.
Yeah.
So talking about the idea of a driver program for mental health research in the UK, you asked us the question, why couldn't we have one? It's a bit cheap, but why do you think we couldn't have one? Or why isn't there a mental health driver program on that set of 6 that you have now?
Because we had it was hard because we had an initial list of 20, 30, 40. So we had to be selective. But what I didn't say is we're very good at leverage. So in our first quinquennium, we were very kindly awarded £53 million from the funders for 5 years, which is for a national institute, it's a lot of money, but it's not a lot of money. And we managed to leverage another 110 million direct and another 100 million in kind. So my view is, if you get the community, and you've got the good ideas, you want to do something that's important, you'll attract the resource.
So it's a question of the community coming to HDR UK with kind of our pitch for.
No, we would work
program.
It's a partnership thing.
Right.
We'd work it up in partnership. Okay. Because what we're keen to do, this isn't a classical program grant. You've got to leave benefit for other people.
Thank you.
I think we will have to wrap up in a moment because we're slightly late for lunch, but
sorry.
I just wanted to ask, no, it wasn't you. We've been slightly running late or gradually moving more late all morning. I just wanted to ask for one other point of clarification. Obviously, medical records is a huge part of what we're talking about here, but proportionately, how much of it is data from, for example, our longitudinal cohorts? And I know there is work with the Longitudinal Linkage Collaboration Initiative, which is related to what you're talking about. So just wondered if you could mention that a little bit briefly.
So he's done great. Andy Boyd and colleagues, Nish Chaturvedi, Jonathan Stern have, through it was Patrick Valance money, basically, enabled the cohorts for linkage, and they're docking into these standards so that because those cohorts should be available to everyone. So I think that's an important dimension. This is not an NHS project. That's a sort of foundation.
Right.
But in 10 years' time, I anticipate that many useful data sources will come from stuff like wearables, sensors, Internet of Things. So this needs to be future-proof, and that's what we're doing, for example, in partnership with ONS. So we're making those data available as well.